Good morning. I'm Dr. Alexis Stevens, a board-certified dermatologist. We're going to have a lot of fun. We have surgery, cosmetics, and medical all mixed in today. 32 patients on the schedule total. Hopefully, they'll let you come along. So let's go have some fun. I just pulled in, and there's already 3 patients waiting. Let's go see them. All right. So I always check beeping my car. Does anybody else do that? Like literally beep their car 5 million times to make sure that it's locked? 3 patients waiting. One's cosmetic, so she's numbing, and then other 2 are medical. I believe hair loss and acne. So we're gonna go see them. This is my staff. Hello. Meet Julie. Meet Maria. I don't know who either of them are because they changed their hair over the weekend. Yes. So first patient is hair loss, and then you have someone?
As well, hair loss as well.
Oh, okay. First 2 patients of the day are hair loss. Alright, so now we're going to do some Botox. Botox is a neurotoxin. There is Botox, Dysport, Nutox, which is also known as Jeuveau, Xeomin. They all act in the same way to actually paralyze the muscle so that when you're moving, like round lines like this, expression lines, it actually paralyzes the muscles that cause the movement and therefore the wrinkles or actual line contractions that happen stop happening. So I just do it so that it looks very nice and natural and that you don't have those lines. You don't look frozen or like some people on television where they look a little scary and they walk around like this all day. I'm not for that look.
She's got so much Botox in her face, I don't know if she's ever gonna decompose.
So part of being in dermatology is keeping abreast with all of the new drugs, medications, and treatments that are coming out. Today we have one of the representatives from a new topical medication coming out for acne. So let's go meet him. Hi.
My favorite. How are we? Oh no, what is this?
This is Eric. Hi.
Hi everybody.
So what are you going to teach us today?
Learn about AMZ today.
Okay.
The first ever topical minocycline for acne.
Awesome. I have 2 patients here right now for keloid treatment. We were going to do Kenalog injections for them in combination with silicone bandages. And we're also going to infuse hyaluronic acid into the scars. So this is a keloid that's responding very well to Kenalog injections. A keloid is basically a scar that goes outside of the normal borders of where the original injury was, making it more than a hypertrophic scar. And we're going to inject Kenalog in here, followed by Aquagold, and we will use hyaluronic acid. Alright, so now we're about to do some under eye filler mixed with some PRP. So we're using this product, Restylane, and it's Restylane Lift, which is a hyaluronic acid. I love to do hyaluronic acid because, one, if the patient doesn't like it, it can be immediately removed, so that's amazing. It's done with something called hyaluronidase. And 2, because it's very safe, it tends to not have any foreign body reactions, and it's very malleable. Other thing that we're using is PRP, so that stands for platelet-rich plasma, and the PRP helps the body to naturally produce its own collagen over time. It's a more natural approach, so think about PRP as allowing the body to do what the filler immediately does. PRP can help the body do that over time, and the filler is more of that. immediate effect. A lot of people come in and they want to see the results now. That's your filler. When patients come in and they're wanting more of a natural approach or something that's going to be long lasting, that would be PRP. I love to combine the two because why not give the immediate effects so people are happy and then build that longevity of PRP as well. So this is the typical setup for doing PRP with fillers. You have your PRP here that's already been spun down and isolated, and then I use a cannula as opposed to doing it with just a normal needle. It's just safer, especially for around the eyes, which is very vascular. And then in fillers, which we already talked about, and I do use Mesogold, which is a little device with 24 karat needles at the end. The needles are actually smaller than a hair follicle, so it doesn't hurt the patients, and this is just an extra boost to give a little bit of extra glow. Want to look that way?
Don't look.
Yeah, like that way. You're gonna have a little pinch. Okay, 1, 2, 3, pinch. You're doing great. You did great. You're done. So we're going to remove it with surgery. You survived. Thank you. Yeah. So that's the same kind of pinch you're going to feel for the surgery. It won't be very much because we will numb you completely before we remove it, okay? So this is a pyogenic granuloma that comes from blood vessels. So okay, so we are about to do a basal cell carcinoma excision. It is nodular. So we're going down to the subcutaneous area. So the fat is being removed. And this patient has a pretty strong history of being vasovagal, meaning that they faint often throughout anything, even just like doing biopsies, surgeries, everything. In the past, she's had a lot of vasovagal experiences. So we have the music going. We're going to be doing a lot of talk aesthesia during the time so that we can kind of distract her. All right, so let's get to it. Do pathology. That way we can confirm that the margins are indeed clear and there are no more cancerous cells. When you remove any skin cancer, whether basal, squamous, or melanoma, you actually want to mark the region that's the top. So we call it 12 o'clock. So we've marked the top of this area here. You can see the basal here in the middle. And the 12 o'clock has been marked so that when the pathologist looks at it, they can tell you if there is any positive margin exactly where it's located. So this is our marking here for the basal. I usually do surgeries midday just to kind of help with the flow of the office, just in case the surgery runs long or it's a squirter, or it's attached to something we didn't really plan for. This way, if it does run a little bit long, it's running into my lunch break versus making all of the rest of the patients for the day late. All right, so we have a full house right now. We have a bunch of full skin exams. People do those for skin checks, just in general to make sure everything is okay. Blue nevus and blue nevi in general are benign and not troublesome. When they're on the scalp, they can be a little bit more worrisome. And if they're growing, we should definitely biopsy to make sure that there is no malignancy. This is alopecia areata. It's in a nice kind of circular oval shape. Xanthelasma is a lipid cholesterol deposit. Half of patients with these have completely normal lipids, and other half have a lipid disorder. And the way that you can get rid of it is by doing something called cryosuppression. surgery or electrocaudication. You can even surgically remove them. But the easiest way and the quickest is using this little applicator. So we have a patient that's coming in with undiagnosed plaques that have been there for years, right? And she has them here on the elbows, and then some plaques here. She also has this, what we're calling a mole, but it's not a mole, it's actually a dermatofibroma, which is just fancy scar tissue name. She was bit by a mosquito at 16 and this developed. So that's how dermatofibromas develop. And then this patch here, she's mentioned that she fell down, kind of going upstairs. Mm-hmm. And then this patch began. So trauma in areas where a patient has psoriasis is called keratinorization. So this is just a psoriatic patch, and then the fact that it came after trauma is keratinorization. Morgellons is super controversial. Is it from Lyme disease, Borrelia spirochetal infection, or is it truly delusions of parasitosis? There's a huge controversy around it. And when I have patients who come in telling me that they're having filaments come out of the body or feel like there's things crawling out of their skin, or they come in with a bag of what has come out of their skin, I do a thorough workup, and I diagnose based off of what I see under pathology, what the pathologist brings back to me, and clinically what we are seeing. I think that everyone is owed due diligence and not just to be written off as delusions of parasitosis. And so we did just have a patient come in and we worked her up thoroughly. We are now about to do laser hair removal on a family of 3, and they also don't want to be filmed, but I'm pretty sure that you guys have kind of seen what laser hair removal looks like. So swelling and edema and erythema on the lower legs bilaterally. So this is stasis dermatitis. Cellulitis does not occur bilaterally on the lower extremities. Okay guys, so that's it for the day. It was a really amazing day. I love dermatology so much, and I hope that you got to have a small glimpse into my world. We did meds, we did cosmetics, we did surgery. We were able to help a lot of people today, and hopefully we were able to keep you entertained. That's how I like to break up my day, to keep myself entertained, and hopefully I was able to keep you guys entertained as well.